Cervical adenocarcinoma originates from the gland-forming secretory epithelium that lines the endocervical canal, the narrow passage that connects the uterine cavity to the vaginal vault. Unlike the more common squamous cell carcinoma, which arises from the flat squamous cells covering the outer part of the cervix, adenocarcinoma develops deep within the mucus-producing glands. Historically, the disease was first recognized when pathologists examined cervical biopsy slides under light microscopy and noted abnormal glandular structures with atypical nuclei. Early detection is crucial because the tumor's biological behavior is often more aggressive when it reaches a size that invades surrounding stromal tissue. Small, confined lesions, FIGO stage, IA, can often be cured with simple surgical excision, whereas larger tumors may require multimodal therapy and have a higher risk of metastasis. The dominant etiologic factor for cervical adenocarcinoma is persistent infection with high-risk human papillomavirus genotypes, especially HPV-16 and HPV-18, which together account for roughly 70 to 80% of cases. The virus gains entry through microabrasions in the cervical epithelium, often during sexual activity. In a minority of women, the viral genome integrates into the host cell DNA, leading to oncogene overexpression. Additional risk modifiers include inherited or somatic mutations that accelerate cell cycling, for example, PT-EN loss long-term exposure to exogenous estrogen, from combined oral contraceptives, tobacco-related carcinogens that impair local immunity and systemic immunosuppression, such as HIV infection. For instance, a 38-year-old woman who has smoked one pack daily for 15 years and uses a combined oral contraceptive for 7 years has a markedly increased cumulative risk if she also acquires a persistent HPV-18 infection. When high-risk human papillomavirus infects a cervical epithelial cell, the viral genome can become episomal or integrate into the host chromosome. Integration disrupts the viral E2 regulatory gene, leading to uncontrolled expression of the viral oncoproteins E6 and E7. E6 binds to the tumor suppressor protein P53 and recruits the ubiquitin ligase E6AP, targeting P53 for proteasomal degradation. Loss of P53 impairs DNA damage-induced apoptosis. E7 binds to the retinoblastoma protein, displacing the E2F transcription factors and driving the cell into S phase irrespective of growth factor signals. Over time, these molecular insults give rise to cervical glandular intraepithelial lesions, abbreviated CGIN, which progress through a sequence of low-grade to high-grade dysplasia before breaching the basement membrane to become invasive adenocarcinoma. Concurrent activation of the PI3K, a KT-MTOR pathway, KRAS mutations, and occasional microsatellite instability further enhance proliferative and survival signals, explaining the heterogeneity observed in clinical behavior. Globally, cervical adenocarcinoma accounts for about 10 to 15% of all cervical cancers, translating to roughly 300,000 new diagnoses and 150,000 deaths each year. The disease burden is disproportionately high in low and middle-income countries, where organized screening programs and HPV vaccination coverage are limited. Age-specific incidence peaks between 35 and 55 years, reflecting the latency period required for persistent HPV infection to undergo malignant transformation. In high-income nations, the introduction of prophylactic HPV vaccines targeting HPV 16-18, and later the non-avalent formulation and routine co-testing with HPV DNA assays have led to a measurable decline in both incidence and mortality over the past decade. However, adenocarcinoma rates have declined less dramatically than squamous cell carcinoma. likely because glandular lesions are more difficult to detect with conventional cytology. Early-stage cervical adenocarcinoma is usually asymptomatic, underscoring the importance of routine screening. When clinical signs emerge, they often mimic benign gynecologic conditions. The most common presenting symptom is intermenstrual or postcoital vaginal bleeding, caused by tumor friability. Patients may also report a watery mucoid discharge that can be odorous if the tumor is necrotic. Pelvic discomfort or a sensation of pressure may develop as the lesion enlarges. In locally advanced disease, invasion of adjacent structures can lead to urinary frequency, dysuria, or rectal urgency due to bladder or rectal compression. Systemic manifestations, such as unexplained weight loss, anemia, or fatigue signal metastatic spread. For example, a 42-year-old woman who experiences occasional spotting after intercourse and increasing pelvic pressure over 3 months should be evaluated promptly with colposcopy and HPV testing. Screening for cervical adenocarcinoma relies on cytology called Pap smear and high-risk HPV DNA testing, either sequentially or concurrently, co-testing. An abnormal Pap, for example atypical glandular cells, or a positive high-risk HPV result, triggers a diagnostic colposcopic examination. During colposcopy, the cervix is visualized under magnification after application of acetic acid and Lugol's iodine. Suspicious areas are biopsied with a punch instrument. Histopathological assessment distinguishes usual endocervical adenocarcinoma from mucinous, clear cell, serous, gastric type, and adenosquamous variants, each bearing distinct morphological hallmarks. Ancillary immunohistochemistry, P16-INC4A, Chi67, and in situ hybridization for HPV DNA help confirm HPV-associated versus HPV-independent tumors. Staging employs the 2023 FIGO system, incorporating clinical examination and imaging modalities, pelvic MRI for parametrial involvement, CT for nodal assessment, and PET-CT for distant metastasis. For instance, an MRI showing a 2.5 centimeter lesion confined to the cervix with no parametrial extension would be staged as FIGO IA2 to IB1. Cervical adenocarcinomas are heterogeneous and are classified according to histologic appearance and HPV association. The most prevalent form is the usual endocervical adenocarcinoma, which is strongly linked to HPV 16/18 and exhibits papillary or glandular architecture with mucin-producing cells. Mucinous adenocarcinoma shows abundant extracellular mucin and may be further divided into intestinal type and endocervical type subcategories. Clear cell adenocarcinoma displays clear cytoplasm due to glycogen accumulation and is often HPV independent. Gastric-type adenocarcinoma mimics gastric mucinous epithelium, is aggressive, and usually lacks HPV DNA. Serous and endometrioid variants are rare and may arise in the context of endometriosis or Mullerian abnormalities. The WHO 2020 classification also emphasizes the distinction between HPV-associated, P16-positive, and HPV-independent, P16-negative, tumors because the latter tend to have a poorer prognosis and may not respond as well to conventional chemoradiation. Management of cervical adenocarcinoma is stage-directed. For early disease FIGO IA to IB1, radical hysterectomy with bilateral pelvic lymphadenectomy is the standard. A fertility-preserving radical tricholectomy with pelvic node assessment is an option for women desiring future pregnancy. Surgical specimens are examined for depth of stromal invasion, lymph vascular space invasion, and margin status, which guide adjuvant therapy. Locally advanced tumors, FIGO IB2 to II-IB receive concurrent chemoradiation. external beam radiotherapy to the pelvis, combined with weekly cisplatin 40 milligrams per square meter and high-dose rate brachytherapy, targeting the residual cervical tissue. For stage IIIB-4 systemic chemotherapy with cisplatin plus paclitaxel, plus anti-angiogenic therapy bevacizumab, is added. Recent trials have incorporated immune checkpoint inhibition pembrolizumab for PD-L1 positive, recurrent, or metastatic disease. Follow-up includes pelvic examination, HPV testing, and imaging at defined intervals every 3 to 6 months for the first 2 years, then annually. Primary prevention hinges on prophylactic vaccination against high-risk HPV types before the onset of sexual activity. The non-avalent vaccine Gardasil 9 covers HPV 16, 18, 31, 33, 45, 52, and 58, collectively responsible for greater than 90% of cervical cancers, including adenocarcinoma. Routine immunization at ages 9 to 14, 2-dose schedule, yields near complete seroconversion and long-term protection. Secondary prevention involves organized screening programs employing cytology, HPV DNA testing, or primary HPV screening with reflex cytology for abnormal results. The shift toward HPV-based screening increases detection of glandular precursors, for example, adenocarcinoma in situ. Lifestyle modifications, cessation of smoking, consistent condom use, and limiting the number of sexual partners further reduce risk by enhancing local immune clearance of HPV. Public health campaigns that combine vaccination with community-based screening have demonstrated greater than 60% reduction in adenocarcinoma incidence in pilot regions. Prognosis is predominantly determined by stage at diagnosis, tumor size, depth of stromal invasion, lymph node involvement, and margin status. 5-year overall survival exceeds 90% for FIGO stage 1 disease, but falls to 30 to 40% for stage 4, reflecting distant metastasis to lung, liver, or bone. HPV-associated adenocarcinomas generally have a more favorable outcome than HPV-independent subtypes, such as gastric type, which exhibit higher rates of early nodal spread and resistance to chemoradiation. Positive surgical margins, lymph vascular space invasion, and the presence of residual disease after chemoradiation are adverse prognostic factors. Molecular markers, including high p16-inc4a expression, low Ki67 index, and intact PTEN, are associated with improved response to therapy, whereas mutations in KRAS or PI3KCA may predict resistance. Accurate risk stratification using these clinicopathologic and molecular parameters guides decisions regarding adjuvant therapy and surveillance intensity. Current research aims to enhance early detection, personalized treatment, and reduce treatment-related morbidity. Liquid biopsy approaches are evaluating circulating tumor DNA, ctDNA, and HPV DNA fragments as non-invasive biomarkers for recurrent surveillance. Immunotherapy has entered the therapeutic landscape. Pembrolizumab received FDA approval for PD-L1 positive, recurrent metastatic cervical adenocarcinoma after platinum-based chemotherapy, and ongoing trials are testing combination regimens with anti-CTLA-4 agents. Targeted therapy directed at the PI3K, AKT, mTOR pathway, for example alpelisib, is under investigation for tumors harboring PI3KCA mutations. Surgical innovation includes robot-assisted radical tricholectomy and hysterectomy, which reduce blood loss and shorten hospital stay while maintaining oncologic outcomes. Radiation oncology is exploring adaptive brachytherapy protocols that tailor dose distribution based on tumor response, potentially lowering toxicity for low-risk patients. Finally, next-generation prophylactic vaccines incorporating additional high-risk HPV genotypes, for example HPV 68, 73, and therapeutic vaccines